I'm Dr. Lauren Feld. I'm one of the GI fellows at the University of Washington.
And I'm Dr. Vijaya Rao, and I'm an assistant professor of medicine at the University of Chicago in the section of gastroenterology, hepatology, and nutrition.
We'd like to thank the GIE editorial board and reviewers for helpful feedback on our manuscript. And on behalf of our co-authors, Drs. David Rubin and Klaus Mergener, we'll present some highlights of this research and next steps moving forward. So we'll start with some definitions. Code status is used in our manuscript, and that describes the resuscitation attempts that a patient wishes. So full code refers to all resuscitation attempts are welcome, meaning intubation and compressions. Partial code refers to limited resuscitation attempts as defined by pre-specified limitations just in discussion with the patient and the team. And DNR stands for do not resuscitate, which means that if in the event of a cardiac arrest, do not want attempted resuscitation. The term code status reversal refers to changing a previously designated DNR, do not resuscitate code status, to a full code, meaning that for a period of time or to just change it indefinitely, the code status will have gone from no attempt at resuscitation to allowing full attempt at resuscitation.
Go ahead.
Oh, sorry. No, after you.
I was just going to thank you for defining those. I think all of that syntax is important in understanding the context of the brief summary of findings that we found. So just to kind of summarize what we did, essentially this was a survey study to evaluate current practices and perspectives of gastroenterologists on their approaches to code status, particularly in inpatient endoscopy. And this was a voluntary anonymous survey of gastroenterologists as well as gastroenterology trainees in the United States. So we had 436 gastroenterologists and 83 trainees complete the survey. And some of the highlights were that respondents felt that in patients with an existing DNR order, respondents reversed code status prior to endoscopy, either all, about 41% of the time, or most of the time, which was quantified at about 18%. When they asked their personal opinion, about a third of respondents supported automatic DNR reversal to a full resuscitation attempt during a procedure, and nearly 20% supported that DNR orders could be sustained, while almost half of respondents supported offering an option for limited resuscitation. I think importantly as well, most gastroenterologists were unaware of their own institutional guidelines, and the vast majority, nearly 81% of respondents, did not know what the national guidelines regarding this clinical scenario would be, with a majority responding that they felt a gastroenterology specific guideline would definitely be helpful.
Yeah, thank you for that helpful summary. So I am curious, since this is the first study that we're aware of that evaluates a gastroenterologist's assessment of and beliefs and practices surrounding code status and endoscopy. Dr. Rao, can you describe a bit what sparked your interest in studying this?
So this is borrowed heavily from a personal experience I had as a fellow. There was a patient that we had been consulted on, an elderly patient with several comorbidities who had been experiencing GI bleeding. My discussion with the family earlier in the day was that we were going to not pursue any procedures on this patient. And then, of course, overnight on a Sunday night, the patient decompensated. And then the family had wanted us to pursue endoscopy in the setting of a sustained DNR order. And as a fellow, I had the impression that all patients undergo an automatic DNR reversal prior to endoscopy or any invasive procedure. And it was a colorful discussion with the ICU overnight that they felt strongly that we should pursue it in the setting of a DNR. And that whole dialogue really sparked the interest into what national guidelines show, what's done, and what's appropriate.
Thank you for your thoughts on that. I agree that it is a very commonly encountered clinical scenario in GI fellowship, and I'm sure beyond. So I appreciate that you were able to sort of turn that experience into a research idea and help clarify things for the rest of us. And on that note, I'm curious if you think that these sort of code status discussions can be used as a window into other ethical issues encountered in the physician-patient relationship in GI.
Absolutely. I think as gastroenterologists, we're really uniquely poised because, our training is really based in internal medicine, but the heart of what we do has to do with procedures. And I think there is a very unique ethical responsibility in being a proceduralist. And I think this is just one small aspect of our responsibility in terms of ethics and really strengthening the patient-physician relationship.
Absolutely. That's why I thought it was interesting that the majority of respondents reported infrequently discussing code status with patients prior to inpatient endoscopy. Our numbers are that 71.5% discussed it for less than 25% of their cases. And if an anesthesia provider was responsible for sedation, 75% of gastroenterologists who responded to our survey thought that it was the anesthesia provider who was responsible for having the code status discussion. So can you comment a bit on the responsibility of the gastroenterologist in having these discussions and on their importance?
I think that's a really important piece to keep in mind, is that this is collaborative. And so, there's several team members involved in this. So oftentimes in the inpatient setting, there's a consulting team, there's the anesthesiologist who's often providing the sedation, and then there's us as gastroenterologists, those who are performing the procedure. So I do think it's very important for each part of the multidisciplinary team to be involved. I think as gastroenterologists, it is our responsibility to certainly at least be part, if not be the sole, um, take the sole responsibility of the discussion in this, again, since we are providing, or since we are the ones that are actually performing the procedure. That being said, though, I think it's very important for the anesthesiologist, if they are participating in administering the anesthesia, to also be involved, because in general, they are responsible should there be a sudden change in vital signs. They really need to know whether or not they should intubate the patient, whether or not they should administer chest compressions, or even giving things like pressors. And so I think, really ensuring that each party is involved in this is important.
That's very helpful. And yeah, I agree with you that as a fellow prior to sort of embarking on this project, I thought that that code status reversal was sort of the recommendation. But I was interested to learn sort of in this in working with you on this and other articles that ASA, the American Society of Anesthesiologists, and the American College of Surgeons guidelines actually do not recommend that DNRs be automatically reversed prior to procedures, and that there should be sort of a shared decision making with the patient and physician. We don't have a GI guideline, as you mentioned. Many of the gastroenterologists requested that in our survey, or reported that they would find that helpful. But I am curious that about 40% of the physicians who responded to our survey reported that they would not feel comfortable performing endoscopy in a patient who had an active DNR order if the patient or their family did not agree to code status reversal or to limited resuscitation. So I'm curious what advice you have for those gastroenterologists who don't feel comfortable proceeding with endoscopy in a patient who has a DNR order.
I think that's a really important question. And I think first and foremost, it's very understandable to have that hesitancy in pursuing procedures in patients who have an existing DNR order. And I think that hesitancy really comes from the concern that if we're pursuing a procedure, if there's any kind of iatrogenic harm that comes from the procedure, there isn't that comfortability in not being able to reverse that. And I think, again, so I understand where that hesitancy comes from. And I think each procedure, each patient should just be evaluated on a case by case level. And so I think there are scenarios, for example, in a patient who may have a malignant bowel obstruction and we're putting in a venting G tube, or, again, in a patient who has, a lot of comorbidities, and without this procedure they may die. And I think really doing kind of a deep dive into the risks and benefits of the procedure is important when deciding what, whether or not to pursue the procedure is probably the most important thing to keep in mind.
Absolutely. That's helpful. Thank you.
And so I think, Lauren, and you did such a wonderful job with this with this project, and I think it's helpful to hear your perspective on some of the discussions from a trainee level. Why do you think trainees and young attendings were more likely to report that they request code status reversal more frequently?
It's a great question. I think there's probably two answers. One of them was that we also found that trainees and young attendings were more likely to discuss code status with patients. So part of it might be that they're more aware that they're requesting a code status reversal during the procedure. The other part is that without sort of the benefit of years of experience, a lot of times people default to sort of what they think is more by the book care. And there was sort of a widespread lack of understanding about what were the policies, both on an institutional level and in terms of national guidelines. And so I think that people are probably mistakenly trying to follow guidelines and believe that an automatic reversal feels a bit more safe, and or that that performing endoscopy on a patient, they should be full code to allow resuscitation attempts, as you mentioned, to try to avoid those interprocedural complications. Whereas perhaps people with more experience, and I'm speculating here, this is not covered in our study, but in trying to interpret the results, my guess is that people with more experience sort of have a greater comfort level in tailoring a bit more to the patient's needs, or maybe did their medical training in a time where where physicians maybe had a little bit more leeway, or were able to sort of make those decisions and decide that they were comfortable proceeding with a DNR order.
Absolutely, absolutely. And kind of going forward, now having done this study and knowing what results you know came at the end, what recommendations would you have for a GI fellow watching this who is told by the anesthesia provider or another staff member that the policy is that DNR orders must automatically be reversed?
It's a great question. So I've been in this scenario, and had to sort of sheepishly tell a few different attendings or anesthesia providers that this is actually an area of research interest in mine, and I'm quite familiar with the policies in place, at both at an institutional level and national guidelines, and think that the importance of patient centered communication and allowing the patient sort of to participate, that they can choose a limited attempt at resuscitation, or if they feel strongly that we can proceed with a DNR order. Importantly, when that has happened, I found that, as is sort of the center of all good medical care, you have to have a really close sort of communication and relationship with the patient or their family member or whoever their decision maker is, and make sure that it's well documented. So if you're and that also is true if you're quote unquote reversing a DNR order. So in the times where I've encountered this, I wanted to be very specific, both in my note prior to the procedure, and in my conversations with the family, about what exactly is okay with them, what constitutes good care for them. So if they say, do whatever you have to do during the procedure to keep me safe, but I certainly don't want anything long term, then we have to document sort of what that means. Are they okay? If, hopefully it doesn't, but if something were to happen during the procedure, are they okay, remaining intubated overnight? Does that mean only a few hours? Are they okay with pressors? Because I've encountered scenarios where having had that conversation beforehand when the patient could participate was important, because it helped us sort of guide decision making and guide conversations with families afterwards. Of course, you don't want to scare them. You don't need to go through sort of a bullet point list of every possible scenario and every everything that goes wrong. The sort of the art part of medicine is being able to communicate the different types of risks and scenarios in a way that allows the patient to really share their views and their goals, and then translating that using our medical knowledge into into specifics. And so that's what I would say is that if you get pushback from from a senior level person, you have to sort of politely but firmly know the guidelines and know your institutional policies and be able to tell them if the patient's wishes, you know, are aligned with that, then we should go with what the patient requests, and then make sure that you're sort of following that up with really careful communication with the patient and or their decision maker to make sure that it's everyone is on the same page and that it's documented well to help, you know, help make decisions later easier and make sure that you're keeping everything consistent with the patient's wishes.
Absolutely. I think you touched on, two really important things. One being documentation, explicitly documenting your conversation with the patient, and also when, if code reversal is pursued, when either the original code status is going to be reinstated. And again, I think part of that is the art of medicine, but whatever we can really document that is a reflection of our explicit discussion with the patient is very helpful. And I think, just in conclusion, in terms of wrapping up what the results of this study mean going forward, I think if you were to be in a scenario where you're getting pushback from a senior level attending or an anesthesiologist, it's not so much their authority necessarily that they're trying to impose on you, but I think it's really a result of lack of knowledge of those guidelines. So I think importantly going forward, what we can really take from this is one, the knowledge of these guidelines should be more widely disseminated. And I think the easiest place to start to do that is in our training program. So I think implementing a formal ethics curriculum that touches on this, as well as other issues, is very important. But also in creating a gastroenterology specific guideline that explicitly states what we should do as gastroenterologists in these clinical scenarios. Again, these are scenarios that are happening more and more frequently with a sicker, with an older patient population where DNRs are far more common. So I think these are very important things to keep in mind going forward.
Absolutely.
And we are so grateful for the opportunity to contribute to GIE, and hopefully you all that are watching have found this to be valuable. Thank you.
Thank you very much.